സംസാരിക്കാൻ പോകുന്നത് on acute ഇല്ലേ? Why we are discussing this topic right now is that because in the last 1 month we are seeing an increased incidence of acute. Have this class today. So what I plan to cover in the next half an hour or this, how would you know that what causes encephalitis, and of course how to investigate, and finally how to stabilize and treat. These are the 4 things that we plan to discuss today. So AES by death with new onset seizures in a person of any age. The seizure വേണം എന്നില്ല. It may be with or without seizures, but you need a fever if a child is admitted and does not have fever at admission. Any fever within 72 hours of admission will also be considered as part of with history of fever. Sometimes they would come to you with altered sensorium, and subsequently you may pick up a fever. That is also equally important. Similarly, what do you mean by sensorium? We call it as an altered mental state, post-ictal drowsiness. So for how long seizure is not a no, that when we say about acute encephalitis syndrome, we are basically thinking about brain infection or brain inflammation. And usually we are thinking about it happening secondary to usually viral infections. But we need to know fever, altered sensorium with or without seizures can happen in case of a demyelinating disease, a localized abscess, a meningitis, and even a toxic and septic emboli, especially secondary to a GI source. So there are so many mimickers also. So we need to be alert for ruling out these mimickers also. So infections of virus. Viruses means they may be viruses which are neurotropic, which are known to cause CNS infections like your herpes simplex virus, a JE virus, or there may be viruses who have your chikungunya, and they can also, or EBV, they can also have a CNS infection. You may have other exanthematous fevers like measles, varicella, which may have concomitant typhus. You may have cases isolated encephalitis without any subsystemic manifestations. Similarly, lepto, you may have isolated CNS infection without evidence where it is endemic in our state. We need to always rule out these conditions. Cerebral malaria in areas where it is common. In Kerala, we see very less of cerebral malaria, but if you're in state, please keep that in mind, especially when you don't have focal signs. And rabies, unfortunately, it's becoming more and more common now, so that has also to be kept in mind. Water, then amoebic meningoencephalitis, which has a very bad prognosis, should also be kept in mind. Now, these are all infections which we said can cause AES. There are different parts of the country. There are certain viruses which are endemic to those areas, and they cause outbreaks. But we also had an outbreak, a sort of an outbreak in Calicut also. So we are getting reports here. In case of JE encephalitis, you have to imagine there are 250 people in the community who are infected with the virus but does not have an encephalitic infection, and only 1 in 250 would develop a real encephalitis. That is why even when you have 1 or 2 cases of JE, sometimes it is flagged as an outbreak. So now to think about non-infective cases, especially autoimmune. Because post-COVID, we are finding a lot of autoimmune disease, even in children. Harms the child is the way the body reacts to it. So keep in mind, acute demyelinating encephalomyelitis, autoimmune encephalitis, febrile infection-associated epilepsy syndrome. That is totally normal child presenting to you with fever, and with fever, refractory seizure. And of course, in an infant, especially with consanguinity, with previous history of fever with altered sensorium, we can never do away with genetic abnormalities. Non-convulsive status epilepticus may be one of the reasons of persistent altered sensorium. Along with imaging, EEG is also a must. And of course, other forms of encephalitis like Bickerstaff brainstem encephalitis may also be presented with fever and seizure. Early morning, was taken to a hospital. From where immediately oxygen, fortunately, the travel distance was more than 2 hours, close to 2.5 hours. And when you received the child still had an active seizure, was tackled. And a child had to be intubated immediately because of poor respiratory effort. Finally, with multiple anticonvulsants, seizures were controlled, so stabilized. But unfortunately, post-intubation, the GCS remained 3. So now you are worried why the GCS is diffuse cerebral edema. So severe hypoxic brain damage leading on to the death of the child. So now different. Now, one thing you have to understand that in encephalitis, even if you do everything right, it might not be possible to only do something more than this, what this child received. So let us see what we are expected to do. That is, what are you with fever, altered sensorium, with or without seizures? Of course, the first objective is to maintain ABC and the airway seizure, and also ensure that it is not recurring. The third is look for raised ICP, look for features of raised ICP, actively manage it, and also think of other may require immediate treatment also. So with these in mind, we already said we have to start with airway, breathing, and stabilization. So any secretions needs to be removed, and is falling back, the GCS is poor. Don't hesitate to use an airway adjunct. Remember, oropharyngeal airway is used in an unconscious child. Conscious child, if you want to protect the airway, you have an option of using a nasopharyngeal airway also. Any child with seizure, which lasts for more than 5 minutes, should be supplied with, because Once the seizure starts, we all know that the respiration is not coordinated. And once the respiration is not coordinated, initially the saturation may be maintained, but subsequently the patient is causing an excitotoxicity there because of the neurotransmitters that are getting released. On top of that, this hypoxia is going to add an insult to the injury. So it's important to prevent hypoxia. Similarly, if the GCS is less than 8 or if the breathing pattern is abnormal, to provide supplementary respiration with a bag and mask ventilation followed by intubation or an LMA with adequate ventilation. This is a very, very important fact. Remember, it is the PCO2 that goes up, and PCO2 is a very potent cerebral vasodilator. In fact, 1 millimeter increase in the PCO2 can increase the having a cerebral edema. The only reason that the ICP, that carbon dioxide has gone up, may increase the ICP beyond who is already having a cerebral edema. So taking care of ventilation is of paramount importance. Now, next is definitely look at circulation. Already said, brain is getting damaged because of the seizure. You should not make the baby hypoxic. Circulation is maintained. In fact, that's the most important factor which decides the ultimate outcome. More than the ICP management, it is maintaining of BP is very important. But here you would say maintain a 50th centile BP so that the blood flow to the brain is maintained. And for that, if the patient is having a poor perfusion, but starting a maintenance is okay. But start and only then we refer if you're planning to refer. If the patient is hypotensive, over 20 to 30 minutes. Usually we prefer 20 ml per kg bolus, and do not use hypotonic fluids. Boluses is with dextrose containing fluids also. Hyperglycemia is also equally bad. But on the other side, what is hypoglycemia? If a blood glucose less than 60 in a child is hypoglycemia. In newborn there, but in a child less than 60 is hypoglycemia, which requires immediate treatment. If it's a small baby, it is D10 2 ml per kg. In children, we, as far as possible, we do not use D25 because 25% dextrose is highly irritant and that can damage your veins. So that is why we don't use D25. We always prefer, and you have detected hypoglycemia and you are not getting an IV line, then the same dextrose can be given through the nasogastric tube also. But if the child is having an actually not advised, you have to get an IV line and give. And remember, after correction of hypoglycemia, never send the child without an IV fluid. After correction of hypoglycemia, and DNS would be given at a rate hourly fluid, like 4-to-1 formula. But I would say in simple terms, just start a DNS at 3 to 4 ml per kg per hour. That should usually be enough for a maintenance fluid while getting, child has had vomiting, child has diarrhea, or the child or a kidney injury, then just start DNS without potassium. So now we have taken care of the airway. We have taken care of child is having seizure. I've taken care of ABC. Is it okay for me to is no? Yes, we all know that 76% of seizures terminate within. Seizure lasts for more than 30 minutes. There is irreversible neuronal injury. Any seizure lasting for more than 30 minutes by 6%. That means if initially you don't control a seizure, the seizure becoming a status is more chance. Why is it so? Because when the seizure lasts for a long time, there is something called receptor trafficking. That is, your GABA inhibitory receptors become internalized, because of which the inhibitory neurons do not discharge. At the same time, the drugs that you give may become less effective. So it is important. Any child who reaches the hospital with a seizure means that the seizure was there for more than 5 minutes. And any seizure more than 5 minutes is taken as a status operational definition and needs to be treated. So no doubt there, we need to treat a seizure. Especially we need to know that seizure per se, not only because of the excitotoxicity that is happening, but when you have a seizure, initially there is a catecholamine surge, the BP goes up. But after some time, as the seizure continues, initially there is an increase in cardiac output, increase in cerebral blood flow. But as the seizure continues, the catecholamines are all depleted, the glucose is depleted, the brain goes in for a hypoglycemic injury. There is failure of autoregulation and the ICP start increasing. This is the time the acidosis also sets in, the BP falls, the hypoxia happens. So there is a multiple ways by which your brain gets damaged just because the seizure was continued beyond 20 minutes. And it may lead on to irreversible brain injury and death. So it's very, very important that we treat the seizure in a timely manner. So what is a first line AED? Any of the benzodiazepines you can use IV, and usually we prefer lorazepam 0.1 milligram per kilogram or diazepam 0.3 mg per kg. Both these should be given slow IV with the eye on the respiration. If you don't have an IV access, what can you do? If you don't have an IV access, you can go and give IM midazolam. Now, what if the child is having a very violent GTCS and moving his limbs so bad that you don't think that an IM would be feasible, or you may have an injury happening there? then of course you can go for a per rectal diazepam or per rectal lorazepam. So these are the options for, and if this is not possible, you can even use nasal midazolam. But I would say these three would be the best way of terminating a acute seizure. And buccal midazolam and nasal can be used, and administering per rectal, I would always advocate. The moment you find that the child is little chubby, the chance that you're going to get an IV line is less. Don't waste your time. Just make the child lie on the lateral side, insert a feeding tube 5 centimeter into the rectum, give the desired amount of the drug, and flush it with air or flush it with normal saline. Then pinch the buttocks so that the drug does not come out. And usually the drug would be effective in the next 5 minutes. So do use, if you don't have an IV line, never ever hesitate to use a per rectal diazepam or per rectal lorazepam. Among the various drugs and routes that we said, yes, we all know IV would be the first one, but IM midazolam is the next one. That is, if you don't have an IV, the preferred one definitely is IM. Per rectal comes next and buccal comes last. So we should know also that which is more effective and which is less effective. Then if the seizure is still continuing in spite of the first line and anticonvulsant that you have given, you can repeat the same anticonvulsant once more. That means the lorazepam or midaz or diazepam, whichever you have given, after 5 minutes, if the seizure is continuing, do repeat it once more. If the seizure is still continuing after 2 doses of the first line diazepam, then you have to use a long-acting drug like phenytoin, fosphenytoin, levetiracetam, or sodium valproate. Sodium valproate, we do not advise in children less than 2 years. We do not advise where an inborn error of metabolism is a possibility. We do not advise when you think that the hepatic injury may be a possibility. And so even though it's a very effective anticonvulsant in children, we often tend to use it last, or we tend to avoid using it. Regarding phenytoin and fosphenytoin, if your hospital has fosphenytoin, that is definitely preferable, because fosphenytoin is water soluble. It can even be given intramuscularly, and extravasation does not cause any problem. Whereas if you're using phenytoin, it has to be given over 20 minutes. That is 1 mg per kg per minute. So the order should be very specific. 20 milligram per kilogram in phenytoin, in 20 ml of normal saline over 20 minutes. That would be enough. Whereas fosphenytoin can be given over 10 minutes, levetiracetam can be given over 10 minutes. Reassess the child after 5 minutes. And if the seizure is still continuing, you can use an alternative agent. That means if you had used phenytoin initially, you can give levetiracetam and vice versa. But never use both phenytoin and fosphenytoin in the same child, because both are same. And if they are not responding, pheno can be used, even though the dose is 20 milligram per kilogram over 20 minutes. In practice, we don't like to give 20 milligram per kilogram. We go for 10 milligram per kilogram because the risk of respiratory depression is high. Now imagine you have given the first dose of lorazepam and the child goes in for an irregular respiration or goes in for an apnea. What do? You are immediately expected to take the bag and mask and give ambu. And if it is a drug-induced respiratory depression, don't panic. After you have maintained the respiration for some time, you might not require even an intubation. Usually when the drug's effect weans off, the child starts breathing. But ensure that the bag and mask is of adequate size. You are getting a seal and you are getting a chest rise and you are getting the saturation. But now if you imagine that you are giving a bag and mask, and or you plan to intubate, and when you're going to intubate, the child has kept his teeth clenched, you should understand that what you are dealing is not a drug-induced respiratory depression, but you're dealing with a seizure which is not responded to lorazepam. So apnea can be seizure apnea, apnea can be drug-induced apnea. Drug-induced apnea, you will get a flabby child, whereas a seizure apnea, you would get a hypertonic child, a posturing child, clenching teeth, or you may have a conjugate deviation of the eye, or you may find the pupils dilated. All that, tachycardia persisting, pupils dilated, conjugate deviation, clenching of teeth, all indicates it is not apnea due to drug, but it is due to seizure apnea, which will in fact respond to the next anticonvulsant rather than anything else. So that also we need to differentiate between the two. So now, most important thing, why children die when you have an AES? Why children die when they have a seizure? The reason is raised ICP and coning. And now the bad encephalitis that you're getting, the coning is happening so fast, you don't get even 12-hour time. The child comes with a short history of fever of 2 days, has a seizure, poor respiratory effort, you intubate, post intubation within 5 to 6 hours, the child goes for a brainstem herniation. So it's very, very important that we pick up these features of raised ICP early. So any child with altered sensorium, think of raised ICP. Look for the pupils, see if there is an anisocoria, if there is a bilateral dilated pupils, which is not reacting very well to the light. If the child is showing a decerebrate or a decorticate posturing, remember, when you have children showing a focal seizures, that is seizure. But when you have a child who's showing a posturing, that usually or may indicate more of a diffuse brain injury, probably secondary to a meningitis or encephalitis with a raised ICP. So posturing should be specifically looked up. And whenever they are there, we should think of a raised ICP. Similarly, specifically look for lateral rectus palsy, irregular respiration, hypertension, bradycardia, apnea. These are all late signs, the triad, the Cushing triad. We need to pick up raised ICP much before that. And we also know that the herniation goes through different stages. And for you to know if the child is really showing features of herniation clinically, remember, papilledema is not foolproof. Sometimes when acute herniation, you might not get a papilledema at all. So there are nothing to really tell you 100% it is there, but these are very, very important clinical clues like anisocoria, bilateral dilated pupils. So for that, most important, I would say, eyes are the windows of the soul, they say. Similarly, eyes are the windows of how your brain works. So never ever forget to look for the eyes. It will give you very, very important clues. Anisocoria, dilated pupils, pinpoint pupils, hemorrhages. So it may give you clues to etiology. It may give you clues to the severity of the disease also. And when the ICP progresses, the eyes will show different changes, ranging initially from a dilatation of the ipsilateral pupil to development of cranial nerve palsy, ptosis, loss of medial gaze, and finally you may have dilatation of the opposite pupil, and finally bilaterally dilated pupils not reacting to light when they have already gone for combing. Till anisocoria, 100% it is reversible. Never give up a child on anisocoria. They may come around with complete neurological status. So now what do you do if you're suspecting a raised ICP? So as I said, anyone having a seizure with any of those features, altered sensorium, pupillary changes, think of raised ICP. If the BP is not maintained, if the patient has hypotension, along with the management of blood pressure, please do give a 3% saline, 5 ml per kg over 1 hour. If the patient does not have a hemodynamic compromise, give mannitol 2.5 to 5 ml per kg, because the osmotherapy really brings down the ICP. And when it comes to an established ICP, it's important that we keep the neck in the midline. Why do we keep neck in the midline? So that the venous drainage is happening. There is no kinking of your jugular veins and pooling of blood in the brains. Keep the head slightly elevated. Maintain a normal BP. Again, emphasizing a normal BP is important. And also normocardia. I already said hypercardia is a vasodilator. Hypoxia is also a vasodilator. So both these should be avoided. Treat fever aggressively. There is no SOS paracetamol for a child with encephalitis. It is paracetamol round the clock. It is one condition where you would advocate sponging because you don't want the temperature to go up. But at the same time, see that the liver is working normally and you're not having transaminitis. So fever has to be treated aggressively with adequate fluids also. Very important to give adequate sedation and analgesia. That's of paramount importance because a child, and if the child does not have a seizure, prophylactic anticonvulsant is also indicated because single seizure in a child who already has an ICP may precipitate a coning. So that is why it is needed. And when you have already intubated the child for a raised ICP, you have an clinical evidence or imaging evidence, then do consider going for a thiopentone coma in refractory ICP. That is very, very important. And it's many times it is effective also. Now, what are the indications for intubation? We all know GCS less than 8 is an indication for intubation. I always say persistent GCS less than 8 or even a fall of GCS by more than 3. Imagine you have a child with a fever with slight drowsiness. You are thinking looks like encephalitis or febrile delirium. But after some time you go and the child's GCS has just fallen from 15 to 12. It has not reached 8. But now your diagnosis of encephalitis is confirmed. And now you know that this child is going to progressively worsen. So in such a situation, you don't wait for the GCS to fall below 8. You would prefer to intubate him early and manage his ICP well. Impending coning, naturally you have to intubate. But impending coning, raised ICP, anisocoria, lateral rectus palsy, if you plan, unplanned intubations are associated with increased risk of brainstem herniation, because while you're intubating, naturally there is a carbon dioxide going up, there is a risk of hypoxia coming. Both of this may tilt the balance in the negative side. So it is important that, especially in a child with raised ICP, you follow the real protocol of rapid sequence intubation, which includes pre-oxygenation with hyperventilation. Just keeping a non-rebreathing mask or just keeping an oxygen NRM is not enough. You have to bag and mask so that you're taking away the carbon dioxide, you are causing hyperventilation. So while you are intubating, even that apneic hypercarbia that develops will not harm the child. So hyperventilation is important. Give osmotherapy before intubation, again to prevent a coning during intubation. Pre-medicate with lignocaine 1 milligram per kilogram so that the reflex increase in ICP does not happen. Sedate with midas and fentanyl. You can induce with drugs like propofol or thiopentone, which decreases the cerebral metabolism, and finally paralyze and intubate. And when you're paralyzing, please do not use succinylcholine because it is a depolarizing paralytic agent, which can increase the ICP. So this RSI is also important. Now, why have you intubated a child with raised ICP? We all say to protect the airway. And then we say that we'll do hyperventilation so that the carbon dioxide comes down and the ICP comes down. But we need to know that hyperventilation is a double-edged weapon. So if you're planning to hyperventilate, we need to know what is your target PCO2, for how long you will hyperventilate, when will you wean, what are your goals. Remember, the hyperventilation can cause cerebral ischemia and in fact lead on to increase in the extent of brain injury. So it is a very temporary measure. You just want to hyperventilate for 2 hours. That is it. That means for the initial 2 hours, you may target a PCO2 slightly. If impending coning, you may target even 25 to 30. Otherwise, what you want is 30 to 35 is your target. And after 2 hours, you would like to slowly bring up the CO2 back to normal. That is between 35 to 40. So that should be clear. It is not something that we do indefinitely because your brain will be damaged. So now we have taken care of airway, breathing, circulation, seizure, raised ICP. So now after managing all that, now is our focus to find out what exactly caused the child. So that is the difference between an acutely ill child and a child who comes to the OPD. In OPD, it's always history followed by examination, whereas in an emergency situation, it is always assess, identify, intervene. The cycle goes on, and then you go and take the history to know what more can be done. So in the history, ask for exposure to animals, which may be a clue for rabies or certain infections. Recent vaccination may be a clue for demyelination. Recent travel may be a clue for malaria. Similarly, swimming in unchlorinated water may be amoebiasis. So that, and also see if there is a leptospirosis in the vicinity, if they have animals at home, if there is a contact with animal urine. So those kind of history we need to elicit to know the etiology. So once you have elicited regarding epidemiological history, then move on to look for systemic symptom signs. This may also give you clue. For example, if you have GI symptoms, it's very unlikely that it is Japanese encephalitis. JE usually does not have GI symptoms, whereas your influenza, your enterovirus, your dengue may have a GI symptom. Similarly, if there is an erythroderma, think of dengue, think of toxic encephalopathy. If you have respiratory symptoms, think of Nipah, influenza, adenovirus, mycoplasma. But this season, all the influenza encephalitis, 90% of them do not have a respiratory symptom. So right now in the state, we are having an outbreak of H1N1. Influenza is very rampant right now. Dengue is also increasing. So both dengue, lepto, as well as influenza has to be kept in mind. If you have people in the family who have upper respiratory infection, child only had a fever, still consider influenza. It does not need a respiratory symptom for you to consider influenza encephalitis, because that's exactly what we are seeing the outbreak right now. So once you've looked for systemic symptoms and signs, look for specific neurological examination. So just imagine initially we were just looking at the pupils, we were just looking for the raised ICP features. Subsequently, you're eliciting the history, doing a proper general examination, and then going for a focused neurological examination, which may again give you clues. So if the child comes with altered sensory, never forget to elicit the reflexes, because we have had outbreaks of enterovirus in the past, maybe 4 months, 5 months back. We had a clustering of enterovirus coming with fever, seizure, altered sensorium with absent reflexes. So, but they all improved well, and there was 100% survival in that group. So, but we need to elicit that, and the stool was positive for enterovirus. Cerebellar signs, if it is there, think of varicella, EBV, mumps. And when you have Parkinsonism, extrapyramidal signs, think of JE, West Nile, and also Nipah can cause that. So, a complete neurological examination, a focused neurological examination may give you clues to the diagnosis also. Now, coming to investigations. So in all children, anyone who's coming with fever with altered sensorium, send a complete blood count. Why do you want a complete blood count? Yes, it may give you a clue whether it is a viral or a non-viral, but remember, anyone who comes with seizure, even when they have a viral infection, because of stress response, they may have leukocytosis. But do look at the hemoglobin. If it is showing a hemoglobin is high than what we expect in the population, probably you're dealing with a dengue encephalitis, or probably you're dealing with a Shigella encephalopathy where the dehydration has led an increase in hemoglobin. So look at that. Do send blood cultures to rule out systemic infections causing toxic encephalopathy. Electrolytes are mandatory, and target a sodium between 145 to 150 so that you are not contributing and hyponatremia causing a brain edema. Blood glucose, periodic monitoring is mandatory. Send for organ functions. There are conditions where the child has come with fever, encephalopathy, you're managing as encephalitis, and subsequently you realize that it is an acute hepatic failure that has set in. So it's important that you look for LFT, not just LFT. Please send PTINR also, because sometimes the labs miss out on transaminitis. This happens because the labs, they will, in computerized lab, they need to take the sample again, dilute and rerun to it to really know what is the transaminitis level. So I would always say it is always preferable along with the LFT to send a PTINR. And of course, renal functions are mandatory. Anyone with fever, a peripheral smear for malarial parasite, and chest x-ray. Many times they might not give you a history of respiratory infection, but you may pick up symptoms or signs. So chest x-ray is also mandatory in all cases of encephalitis. Second line investigations, if the abnormal sensorium is persisting, neuroimaging is mandatory, EEG is mandatory. Someone has had a fever with a focal seizure, child sensorium is normal, they can take EEG in leisure, no problem. But if someone who has come to you with fever, altered sensorium, and the altered sensorium is persisting and you don't have a diagnosis, non-convulsive status is definitely an entity that you should be thinking of, especially if associated with tachycardia, dilated pupils, or any subtle signs, then EEG, bedside EEG is mandatory. CSF study, again, you may decide when to do, may differ. For example, if the patient is showing acute raised ICP, you may defer CSF study at that time. Anyone with an altered sensorium, we have to take the imaging and then only go for CSF study. We should not be missing an ICSOL there. We should not be missing a CNS bleed there. So persistent altered sensorium, CSF study is only after neuroimaging. But whenever possible, definitely do. And the CSF has to go for viral PCR should be sent. Now, we should know that when we send for viral PCR, don't expect miracles there. Because most of the time, by the time the patient is presenting to you with encephalitis, the virus has already left the CNS. So you might not get a CNS viral PCR positive. So what should you do? When you're send the nasopharyngeal swab for PCR. And when you're sending the nasopharyngeal swab, it is not only the respiratory viral panel you want. You want the respiratory viral panel because adenoencephalitis can happen, mycoplasma encephalitis can happen, influenza encephalitis can happen, but also ask for the neuroviral panel in the respiratory NP swab, because many a time those can be picked up from the respiratory part also. Even the causality cannot be proved beyond doubt, but that gives you a clue when all others are negative. And again, emphasizing, do not forget to send influenza PCR during this outbreak of any child presenting to you with fever with altered sensorium and seizures. Then, of course, your tropical infections like dengue, lepto, and scrub, when indicated. Most of the panels do not have JE. This also should be kept in mind. So for JE, and often JE PCR are negative, you will get a serology positive. So do send JE serology if the symptoms are persisting, and if you have diarrhea, vomiting, a stool PCR for entero and Shigella should be sent. We should not be under the impression that Shigella encephalopathy will have blood in stools. Many Shigella infections like Shigella soni, only 10% will have blood in stools. So if you have someone with diarrhea with altered sensorium presenting in shock, Shigella is definitely up on the list. Antibiotic cover should be mandatory, and stool should be sent for culture as well as PCR. Cultures we often do not get, but when we get to do a PCR, PCR is often positive. And third line is definitely your autoimmune workup. In the present scenario of the post-COVID, where in children as well as in adults, the autoimmune incidence is going up, this should always be kept in mind. And any child who presents to you with recurrent episodes of altered sensorium, who gives you a history of previous child loss, who gives you a history of consanguinity, especially in infants, do think of an inborn error of metabolism and send for lactate ammonia, TMS, and GCMS. Now, a word about storing and transportation of samples for serology. If you're planning to send a sample for serology, say for JE or any other serology, take 5 ml of blood, keep it at room temperature, allow it to clot, and then keep it at 4 to 8 degrees centigrade. This is only for 24 hours. If you're planning to send this sample to NIV Pune or somewhere far for analysis or serology, then please do not freeze whole blood. Otherwise, also, anytime do not freeze whole blood. Then in this situation, what you have to do is you allow the blood to clot, separate the serum, and the serum can be stored. The serum can be stored at 4 to 8 degrees centigrade for up to 7 days. And if you are expecting a delay, it can even be frozen. I hope that is clear. And CSF should always be stored at 4 degrees centigrade. And while transportation also, the cold chain has to be maintained. That is both for PCR as well as for serology. Now coming to the specific treatment. Till now, we were discussing about general treatment. Specific treatment, suspecting herpes, definitely give acyclovir 10 milligram per kilogram per dose as an infusion 8 hourly. And once it is proven, it needs to be given for 21 days. But remember, if you've done an LP in the first 3 days and the CSF PCR is negative for HSV, we cannot say that the child does not have HSV. If the person has features suggestive of an HSV encephalitis, we need to repeat the PCR after 5 to 7 days. If the second PCR is also negative, then you can confidently say that the patient does not have herpes. Then if you're suspecting a varicella zoster, especially with your cerebellar signs, there also acyclovir is indicated. In this scenario, in present condition, anyone coming with fever with altered sensorium, features of encephalitis, please do empirical oseltamivir, even when the child does not have a respiratory symptom. Then mycoplasma, scrub, and lepto, when indicated, should be thought of, which can be treated either with doxy or azithromycin. Then if you're thinking of an immune-mediated phenomenon, that is when you have a very rapid deterioration in a child, do consider immunomodulation also. That is methylprednisolone, IVIG, or plasmapheresis. In some persistent cases, you may require higher immunomodulation with drugs like rituximab also. So, and finally, to conclude, which I already said, if you are suspecting an inborn error of metabolism in an infant who is presenting to you with seizure with encephalopathy because of the previous history or consanguinity, then definitely stop the feed so that you're decreasing the substrate. IV fluid maintenance should be a D10 containing maintenance. That means it doesn't mean that you're going to give a plain D10. What you normally do is you will take DNS to 75 ml of DNS, you will add 25 ml of D25. That will give you a D10 containing DNS. So that will increase the dextrose concentration and give it at 1.5 times the normal so that the metabolites which is formed is excreted in the urine. Meanwhile, if you are not suspecting a fatty acid oxidation defect, that means a child who has come to you with hypoglycemia and has urine ketones positive, that means highly fatty acid oxidation defects are unlikely. In that situation, you can give intralipid. If there is a possibility of fatty acid oxidation defects, please do not use intralipid. And what will intralipid do? Intralipid will again promote anabolism and prevent catabolism. That is very, very important. Because why does a child go in for destabilization only when the fever comes? Because that time the metabolic demand is increasing. So if you are able to provide the stress, if you're able to handle the stress, if you're able to provide adequate calories, this alternate pathway will not be active. And that way the toxic metabolites will not be synthesized. So adequate nutrition, adequate dextrose concentration is very, very important. And the moment you get a glucose level above 180, do start insulin, because insulin is the one which is going to promote catabolism. So you want to increase excretion, stop catabolism, promote anabolism. If it is organic acidemia, do consider carnitine 200 milligram per kilogram per day. If the patient has acidosis, treat with soda bicarb 0.3 to 0.5 milliequivalents per kg. It's not 5, it is 0.5 milliequivalents per kg per hour to a maximum of 1 to 2 milliequivalent. And if there is hyperammonemia, you can either use medical management like sodium benzoate and hydrogen and arginine hydrochloride for removal of ammonia. You can even think of dialysis if the ammonia is very high. And in organic acidemias, metronidazole may be added to decrease the production of organic acids from the gut flora. So that was nutshell in how do you suspect, how do you evaluate, how do you manage a case of AES. So the main take home messages: suspect AES in any child presenting to you with fever with altered sensorium. The first priority is stabilization of airway, breathing, and circulation. All the three are equally important. Treat seizure, that is mandatory because it will harm the child. Always anticipate raised ICP in a child with altered sensorium. Look for signs of raised ICP and manage ICP vigorously. Send appropriate investigations, which would include PCR as well as serology, and always look for the cause of encephalitis or cause of altered sensorium and treat the cause. Thank you.